Hi everyone, thank you for joining us today. My name is Nicole Suri, and on behalf of Megan, I'd like to welcome you all to this Megan Masterclass with our guest speaker, Dr. Christos Papadelis. I'd like to ask attendees to please use the Q&A button on your screen to send in questions at any time during the masterclass. There will be time for our guests to answer questions you may have at the end of this session. This webinar will be available to watch on demand on the Megan website at a later date. So it gives me great pleasure to hand over to Dr. Christos Papadelis, who will officially kick off the webinar. Thank you very much.
Okay, good morning, everybody. First of all, I would like to thank Megan for the invitation. Today, I will speak about the work of my research team on the most recent advances and future horizons regarding electromagnetic source imaging in the presurgical evaluation of children with drug-resistant epilepsy. But before doing that, I would like to introduce myself. I'm Christos Papadelis. I was born and raised in Greece. I graduated from the Aristotle University of Thessaloniki. My PhD was on the development of an EEG-based biomarker for the detection of the level of the sleepiness from drivers on board. And after my graduation, I had my first postdoctoral training in Brain Science Institute in Riken in Tokyo, in Japan, on MEG with Dr. Ioannidis. I received training on source localization methods. Then I had my second postdoctoral training in a very beautiful place in the middle of the Italian Alps in University of Trento. I worked there with Professor Christoph Braun, with cognitive neuroscientists on emotional processing. And finally, I received my first faculty appointment in Harvard Medical School, and I became also manager of the baby MEG facility in Boston Children's Hospital. I developed my own team there. I was promoted to assistant professor and director of the clinical MEG program. And after spending 10 years in Boston, I decided to move here to Texas to direct the Neuroscience Research Center at Cook Children's Healthcare System. And I'm also faculty at the University of Texas and Texas Christian University as professor. So that's me, and today we'll talk about epilepsy. Epilepsy is a common neurological disorder that affects approximately 1 in every 26 people in the world. It is characterized by abnormal brain activity that cause like clinical seizures or periods of unusual behavior, sensations, and sometimes loss of awareness. And although epilepsy can be seen at any age, it's most common in young children and older adults. The first line of treatment for patients with epilepsy is through the use of anti-seizure drugs that are able to control the clinical seizures. So there are nowadays like more than 25 anti-seizure drugs, and particularly the last 20 years, we see a booming in the discovery of more anti-seizure drugs from the pharmaceutical companies. But despite of all these efforts, like up to 1/3 of children with epilepsy, they are unable to control their seizures with anti-epileptic drugs, and they suffer from what's called drug-resistant epilepsy. And epilepsy is not only persistent clinical seizures. Like children with epilepsy, they suffer from other significant comorbidities, such as the side effects of anti-epileptic drugs, cognitive problems. They have depression, anxiety, and they have also increased mortality for sudden death, a condition that is called SUDEP. For these patients, resective surgery is the best available treatment that offers the possibility the patient to become seizure-free. The goal of the surgery is the complete resection or disconnection of the area that is called the epileptogenic zone, is the brain area that is indispensable for the generation of the seizures, while at the same time we should preserve the eloquent cortex in order to avoid any kind of brain physiological function, any loss in brain physiological function. And epilepsy surgery is a quite effective treatment. It has been shown that more than 60% of children with drug-resistant epilepsy who undergoing surgery, they remain seizure-free at least 5 years after surgery. However, there are several patients with focal epilepsy who have poor outcome after surgery, and this is the patient cohort I'm trying to help with my research. The efficiency of epilepsy surgery has been significantly improved over the last 10 years. One of these developments is the laser ablation. Cook Children's is actually one of the pioneer hospitals in the country which offer this type of treatment. So there's no need for big craniotomies anymore. We simply open a small hole with a drill on the patient's scalp. we insert a laser probe inside the patient's head and we deactivate with heat the brain area that is responsible for the initiation of the seizures. So in order to be successful, epilepsy surgery requires the delineation of the epileptogenic zone, which is, however, a theoretical concept and cannot be measured directly. It is usually assessed indirectly on the basis of different diagnostic approaches, which provide different cortical zones that are considered estimators of the epileptogenic area. So we have like several cortical areas which overlap to each other. For example, we have the seizure onset zone, or the brain area where the seizures are initiated, the irritative zone, the brain area where interictal spikes they occur. We have the epileptogenic zone in some cases if the patient has some kind of anatomical abnormality that can explain the underlying seizures and so on. And in order to assess all these cortical areas, we use several non-invasive tools such as the video EEG monitoring, the MEG, the MRI to check for any kind of underlying anatomical abnormalities, metabolic techniques such as the PET and the SPECT, and neuropsychological tests. So this patient is going initially under what is called presurgical evaluation, or phase 1, where all these tests are performed, and each of these tests give us information about one specific area in the brain. Among all these cortical regions, the irritative zone is the area where the interictal spikes are seen and is regarded as the most classical biomarker of epilepsy. Its main advantage is that it can be easily localized with non-invasive methods such as the MEG and the high-density EEG. On the other hand, its main limitation is that it's relatively large and often overlaps with eloquent areas which are critical for the different functions of the human brain. In order to detect and localize the irritative zone in patients with drug-resistant epilepsy, several centers, they perform simultaneously MEG and high-density EEG recordings. In this video, we'll see the protocol that is used by one of my collaborators, like Steve Stafferbin at Massachusetts General Hospital. We initially place on the child's head high-density EEG net, and then we ensure with a conductive gel conductivity between the EEG electrodes and the child's scalp. We also place peripheral electrodes for measuring other recordings, like, for example, electrooculography or electrocardiography, and we use this kind of signals for removing biological artifacts from the child's from the MEG or the EEG recordings. Then we ensure that the resistance between the EEG electrodes between the EEG electrode and the child's head is below a specific threshold. Usually this is 10 kilo ohm. We place some coils, usually 4 of them, on the child's head, and we digitize these coils with a magnetic stylus in order to know their exact location with respect to the child's head anatomy and the MEG sensors. Also, we digitize several extra points in order to be able to roughly reconstruct the anatomy of the child's head. And then finally, we accompany the child inside of the magnetically shielded room where the MEG recordings are performed. We ensure that the child feels comfortable, so we place some cushions on the child's head. And finally, we place the child's head inside of the MEG helmet in order to start performing the recordings of the simultaneously MEG with a high-density EEG. So this is the state of the art setup we have at Cook Children's, where we perform simultaneously recordings of the MEG with the high-density EEG with more than 550 sensors. For the high-density EEG, we use the MagSteam EGI geodesic system that offers a full head coverage with 256 channels. And with this system, there's no need for a conductive gel to be used. We simply soak the electrodes net into a saline solution and we place the net on the child's head. There are 3 candidate mechanisms that explain the generation of the MEG and the EEG signal. We have axial potential propagating across the axon dendrites, stemming from the soma of the neuron and traveling up to the next neuron. We have postsynaptic currents from one neuron to the next one through the synapses, and also back propagating spikes following the opposite direction of axial potential propagation with a similar speed. And among these 3 mechanisms, like postsynaptic currents, is the neurophysiological mechanism that seems to generate the most prominent MEG and EEG signal activity. The desirable case in epilepsy is the recording of several interictal epileptiform discharges, or what's called spikes, which they occur either on the high-density EEG or the MEG signal. And in some cases, as we see here, for example, we see spikes in either one of these modalities, and we explain later the reason behind that. But MEG and high-density recordings are performed at the scalp, so the challenge we face is to identify and localize the underlying generator that caused this interictal activity that we observed at the scalp. The problem we face is that EEG electrodes and MEG sensors outside the scalp, they record a mixture of activity from several underlying brain generators, what is termed a superposition of source activity. And I will try to visually explain that. So let's assume, for example, that you have a source located somewhere in the occipital cortex that generates activity with a specific frequency content. And we have another, a second source, which is simultaneously active with the first one, that is located somewhere in the frontal cortex and generates activity with a higher frequency than the original one. An EEG electrode or a MEG sensor that is located somewhere in the middle between the two sources will record a mixture of activity from both sources. An electrode or a sensor that is located closer to the first source will record still a mixture of activity from both sources, but stronger activity from the first one, while an electrode or a sensor that is located closer to the second frontal source will record stronger activity from the second frontal source. So the problem we face is that electrodes at scalp or MEG sensors outside the scalp, they record brain activity from several underlying brain generators. And the task we have is like to identify these generators and localize them with high precision. To do so, we have to solve two complex mathematical problems, namely the forward problem and the inverse problem. And I will try not to go into details. So in the forward problem, we know the number, the location, and the strength of the generators inside of the brain, as well as the physiological properties of the different head tissues. And what we have to estimate the electric and magnetic activity that these generators, they produce outside the scalp. In the inverse problem, we know the activity that we measure with the MEG and the high-density EEG outside the scalp, and we have to estimate the underlying generators inside of the brain that produce this kind of activity. So the solution of the forward model is straightforward, but on the other hand, this solution of the inverse problem, so the inverse problem has an infinitive number of solution. It is what is called the ill-posed problem, and in order to solve it, we need to apply some kind of constraints in our solution. There are several kinds of solutions to the inverse problem with its own advantages and disadvantages, and among them, the equivalent current dipole is the most widely accepted in the clinical practice. So with dipole fitting, we assume that like all observed activity with MEG or high-density EEG at one specific time point, for example, at the peak of an interictal spike, is generated by a single generator inside the human brain. So this generator models actually the brain activity of thousands of neurons, which are simultaneously active in a focal area of the brain. And the dipole can be characterized by three main features: its location, its orientation, and its moment or its strength. The conventional way to delineate the irritative zone with MEG and high-density EEG is by modeling each interictal spike with a dipole. So we usually consider an a priori selected threshold for the goodness of fit around like 80 to 90%, and we keep only the dipoles above this threshold, assuming that the other dipoles, they reflect less epileptogenic regions. So the desired case is a clustered group of dipoles in a focal area of the brain, and we have now several studies showing that surgical resection of this dipolar cluster render the patient seizure-free in cases even where patients, they have a normal MRI. My group performed recently a more systematic assessment of the localization accuracy for the magnetic and electric source imaging by quantitatively estimating the localization error for three electrophysiological methods: the conventional EEG with 20 channels, the high-density EEG, in this case with 72 channels, and the MEG with 306 sensors, and also further determine the clinical utility of these methods in the presurgical evaluation of children with drug-resistant epilepsy. We retrospectively analyzed MEG and high-density EEG data, which were recording a cohort of 25 children with drug-resistant epilepsy. The children, they have undergoing epilepsy surgery and recordings with intracranial EEG using strips, grids, and depth electrodes. We initially identified interictal spikes in both the MEG and the high-density EEG signals. We actually had two readers who were fully blind to each other and also blind to the patient's medical record. And the interictal spikes, they were localized by using the equivalent current dipole method performed at the peak of the spike. These are the findings from one characteristic patient from our cohort, that also the figure in the cover of the journal. We see the localization findings for the three different non-invasive techniques: the low-density conventional EEG, the high-density EEG, and the MEG. And we observed a scattered group of dipoles covering the left temporal regions for the conventional EEG, a more tight cluster of dipoles for the high-density EEG, and finally a very focal and tight dipoles cluster for the MEG and the intracranial EEG. We actually compared the localization accuracy of each of the three non-invasive techniques with the invasive one that served as the gold standard. To quantify the localization accuracy, we estimate the distance of the non-invasively estimate dipoles from the closest intracranial EEG contact, the distance from the intracranial dipoles, and the distance from resection. The highest number of dipoles which were covered by the intracranial EEG were seen with the MEG, 92%, followed by the high-density EEG, 80%, and 70% for the low-density EEG. That was a quite impressive performance. MEG presented the lowest localization error, around like 15 millimeters, followed by high-density EEG, approximately 20 millimeters, and the low-density EEG, approximately 25 millimeters. We observed that distance of the dipoles from resection was significantly lower for the patients with good surgical outcome compared to poor surgical outcome. The gold standard that was regarded the intracranial EEG, so the lowest distance from resection, around 7 millimeters, followed by the MEG, around 14 millimeters, the high-density EEG, 17 millimeters, and finally the conventional EEG, 23 millimeters. The classical approach of selecting dipoles in electric and magnetic source imaging presents, though, some limitations. Dipoles with even high goodness of fit, they can depict a combination of the epileptogenic zone and some of its propagation zone. And also their selection is based on a priori selected threshold that is defined empirically and may change depending on the number of the used electrodes or channels. In order to address this problem, we developed a new metric called dipole clusterness that can offer a quantitative index of the epileptogenicity of the area where the dipoles is pointing out. So its dipole receives a clustering index that quantifies the number of dipoles which are in its neighborhood. So dipoles with several other dipoles in their vicinity, they have higher clusterness, while dipoles with few dipoles in their vicinity, they have low clusterness. We applied this method to a cohort of 10 children with drug-resistant epilepsy having a normal MRI. And these are the most challenging cases since there's no underlying anatomical abnormality to formulate a good hypothesis about the approximate location of the epileptogenic zone. So by using our clustering method, we showed for both electric and magnetic source imaging on high-density EEG and MEG that dipoles with higher level of clusterness had lower distance to resection. More importantly, the distance from resection was significantly lower for the clustered dipoles for patients with optimal compared to suboptimal surgical outcome. By using our clustering approach and the state-of-the-art setup we have at Cook Children's that offers simultaneously MEG and high-density EEG recordings with more than 550 sensors covering the entire head, we're able to render seizure-free an adolescent who suffered from seizures for 16 years. The patient actually was admitted previously in another level 4 epilepsy center. He had already stereotaxic EEG, and the recommendation for her was to place a deep brain stimulation. The patient MRI was regarded as normal, and by performing recordings with MEG and high-density EEG, we identified several interictal spikes on the sensors covering the right frontal areas. Source localization with dipole clustering showed a tight cluster for all three neuroimaging modalities: low-density EEG with 20 channels, high-density EEG with 256 channels, and MEG. And reevaluation of the patient's PET showed a tiny hypometabolism at the same location where the dipole clusters they were located. So the clinical team finally decided the placement of stereotaxic EEG with several electrodes covering the right frontal and temporal regions. And the intracranial EEG captured one focal onset clinical seizure that was characterized by high frequency onset activity in the right anterior insula that was ablated with laser, rendering the patient seizure-free for more than a year after 16 whole years. Here we see another case where MEG and high-density data were particularly helpful in a 4-year-old patient suffering from tuberous sclerosis complex. The complex is a genetic disorder that causes like several tumors in the patient's brain, which often cause seizures. We see the tumors for these patients with green color in the 3D plane of the patient's MRI. And the task is to identify the tumor that is the most epileptogenic in order to resect and the patient to become seizure-free. So by using simultaneously MEG and high-density EEG recordings, we identify interictal spikes and we localize them with equivalent current dipoles. The dipoles, they formulate a tight cluster with both MEG and high-density EEG that was located in the vicinity of a calcified tumor. The tumor was resected and the patient became seizure-free. The problem we face with a conventional MEG system is that they have been designed for adults. In these systems, the head of the child, particularly those who are up to 3 years of age, is far from the MEG sensors, reducing significantly their sensitivity. In order to deal with this problem, my previous team at Boston Children's Hospital, led by Yoshi Okada and myself, built a whole head MEG system that is particularly designed for children up to 3 years of age. Here we see some examples from patients with a baby MEG system. These are data from a 2-year-old boy with drug-resistant epilepsy having a possible focal cortical dysplasia in his right frontal cortex. The baby MEG recordings indicate interictal spikes, which are visible in both left and right frontal magnetometers, though activity was more prominent in the left frontal sensors. Source localization with dynamic statistical parametric mapping localized the interictal spikes in the vicinity of a focal cortical dysplasia. PET scan also identified a high hypometabolism in the same cortical regions, and the anatomical abnormality was finally resected and the patient became seizure-free. These are data from another even younger child. This is a 9-month-old boy having seizures with left arm elevation, shoulder tweaks, and eyes rolling up. And with a baby MEG system, we identify several interictal epileptiform discharges at the magnetometers covering the right temporal regions. Most interictal activity was located in few magnetometers covering the right temporal lobe, and by using equivalent current dipole, we localized the interictal spikes and found to formulate a tight cluster of dipoles. The cluster of dipoles was located in the vicinity of a focal cortical lesion that was in the right temporal lobe, which was resected and the patient became seizure-free. So, as we mentioned before, some interictal spikes, they occur in both the EEG and the MEG, but others only in the EEG signal. And this is because the two modalities, they have different sensitivity profiles, mostly based on the orientation of the underlying sources. So, for example, like the MEG is blind to detect sources that they have a pure radial orientation to the MEG sensors, while it's partially sensitive to sources with oblique orientation, and has a full capacity to detect brain sources with tangential orientation. On the other hand, like the EEG is sensitive to all these kind of sources in terms of orientation, but is more sensitive to noise compared to the MEG. To deal with this problem, my team has combined the findings of MEG and high-density EEG into the same solution by solving the forward and inverse problems separately for each modality and join the combined solutions. So we see here the findings for one of the patients for the classical dipole fitting in our clustering algorithm for the high-density EEG, for the MEG, the combined solution, and the intracranial EEG that was regarded as the gold standard for comparisons. And we want to test the hypothesis that the combination of electric and magnetic source imaging provides improved source localization of the epileptogenic zone and predicts better surgical outcome in patients with epilepsy compared to the individual modalities. To test our hypothesis, we use two different metrics. We use the distance from the clinically defined seizure onset zone and the distance to resection. We ran this kind of analysis in a group of 25 children with focal cortical dysplasia. we found that in good outcome patients, our clustering algorithm showed a lower distance from the clinically defined seizure onset zone and the resection for all modalities. More importantly, combined electric and magnetic source imaging showed the best findings with a mean localization of approximately 7 to 8 millimeters error that was comparable to the electrical source imaging on intracranial EEG, which served as the gold standard. Here we see the rho curve analysis for the classical dipole fitting and for our clustering approach. The best values of sensitivity and specificity, as well as the area under the curve. This means the highest predictive value of surgical outcome among the non-invasive methods was observed for the clustering method performed on the combined MEG and high-density G solutions. So these measures, they were followed by the clustering algorithm on the individual modalities, the MEG and the high-density G. And based on these findings, we can conclude that electric and magnetic source imaging, which are derived from simultaneous recordings of MEG and high-density G, they can offer significantly improved localization of the epileptogenic focus for children with drug-resistant epilepsy compared to individual modalities. However, in several cases, there's not a focal source to be identified with the MEG or the high-density G in order to be resected and render the patient seizure-free. In these cases, it is believed that there's a whole epileptogenic network that is involved in the generation of the seizures, identification and resection of the pathological hubs within this network will eventually render the patient seizure-free. So for these cases, it has been hypothesized that epileptogenic activity is generated within the epileptogenic zone network and later propagates to other areas of the brain. The delineation of the epileptogenic networks can be done by using functional connectivity measures. There are actually several studies nowadays like they're doing that quantifies the temporal coincidence of spatially distanced neurophysiological events. Functional connectivity has been usually applied on pairs of recordings from intracranial EEG that we know that has a high signal-to-noise ratio. And the functional connectivity values, they range from 0, which indicates like no functional connectivity, to 1, which indicates the maximum temporal coincidence of the signals. So the results of this analysis is a connectivity matrix characterized by n, multiple n elements, where n is the number of intracranial electrodes. In this study, my group explored the idea of delineating the epileptogenic networks by using a virtual implantation of sensors, estimating through solving the inverse problem on non-invasive recordings of MEG and high-density EEG in a cohort of children with drug-resistant epilepsy. So we identify segments of data with both from both intracranial EEG, high-density EEG, and MEG interictal recordings with either spikes or without frank epileptiform activity, and estimate the functional connectivity and the derived graph centrality measures for different frequency bands. The goal is to assess whether this kind of functional connectivity measures, they were able to identify the epileptogenic zone and predict the surgical outcome. We found that for both segments, with and without frank epileptiform interictal activity, functional connectivity was significantly higher inside resection compared to outside in a cohort of 24 patients who undergone epilepsy surgery, and they have a good surgical outcome for several frequency bands. We observed similar findings for the non-invasively functional connectivity measures, which were derived from the MEG and the high-density G analysis. Increased functional connectivity for the virtual channels located inside resection compared to outside for patients with good surgical outcome, but not for patients with poor surgical outcome. Here we see two characteristic examples of patients, one with good and one with poor surgical outcome. With green, we see the resection volume, and from the top to the bottom, the functional connectivity measures for the actual intracranial EEG contacts and the virtual channels placed on approximately the same locations where the intracranial EEG was placed. We see a significant increase of functional connectivity within the resection on the same locations for both the invasive and non-invasive recordings for the good outcome but not for the poor outcome patients. So our data indicate that non-invasive methods such as the MEG and the high-density EEG, they can delineate the epileptogenic network and render the patients with drug-resistant epilepsy seizure-free. Over the last decades, there's an increased interest in the fast oscillatory activity in the epileptic brain, high-frequency oscillations, or what's called HFOs, in the range between 80 and 250 Hz. They have attracted the attention of translational research as a promising biomarker of epilepsy. However, the vast majority of HFO studies, they report findings from intracranial EEG. And although the use of intracranial EEG electrodes ensures that we have like a high signal to noise ratio, it limits the applicability of such a promising interictal biomarker to a late stage of the surgical workup, and that's to a restricted pool of candidates for surgery. The possibility to define the brain area that generates high frequency oscillations using non-invasive techniques, such as, for example, like the MEG or the high density EEG, would largely augment the possible use of HFOs in the clinical practice by expanding the applicability to an early stage of the surgical workup and enabling their application to a wider proportion of patients. Also, the use of full head techniques to define the HFO zone would overcome the limited spatial sampling of intracranial EEG, helping to also optimize the planning and placement of intracranial EEG electrodes. Back in 2009, there were very few people who believed that HFOs can be localized with MEG. And during my postdoc training with Dr. Ioannidis, I was one of the first to provide evidence that MEG can detect and localize weak transient activations and the human HFOs with an accuracy of a few millimeters at cortical and subcortical regions. By using a phantom construction that resembled the basic properties of the human head, we were able to generate artificial signals that contained all frequencies. So we actually implanted dipolar sources inside a plastic phantom construction in 4 different locations, which represented brain areas that show different levels of difficulty to be localized, a superficial source and more deep sources. And we activate this kind of dipolar sources with a sharp spike signal that contains all frequencies. By filtering the signal in the frequency band of HFOs, we're able to generate an artificial signal that resembles high frequency oscillations from human recordings. And we localize this kind of activity with different source localization techniques and show that HFOs can be detected and localized with an accuracy of a few millimeters for superficial cortical sources, while HFOs in deeper areas of the brain, they are hard to be seen and can localize with significant lower localization error. For all these reasons, like the detection of HFOs using non-invasive presurgical techniques is a hot topic of research. And actually nowadays, several research studies from my group and others, they have shown increasing evidence that HFOs in the ripple frequency range between 80 and 250 Hz, they can be non-invasively detected and localized with scalp EEG and MEG. Here you see a portion of data from high-density EEG and MEG recordings in a child with drug-resistant epilepsy, where ripples, they were overlaid on spikes and are clearly seen on both signals when they are filtered between 80 and 150 Hz. To ensure that this activity is not an artifact or the byproduct of filtering, we also performed time frequency analysis where we observed an isolated island of activity for both the MEG and the high-density EEG. And this kind of criteria ensures that this is a real HFO activity and not a filtering effect or a kind of a technical artifact. For the source localization of HFOs, we used the wavelet maximum entropy on the mean method. Contrary to the localization of spikes that can be performed using, for example, like the dipoles, as we described before, at specific time points, usually we go the peak of the spikes. The localization of HFOs needs the use of well-suited methods for this application, since we don't have a specific time point of interest, but rather we have a window of oscillatory activity to localize. So in this study, we use the wavelet maximum entropy on the mean method, which has been developed exactly for localizing oscillatory activity in specific time frequency windows that in our case was set equal to the time window previously detected and the frequency range between 80 and 150 Hertz. The results of the HFO's localization was compared with the seizure onset zone and the irritative zone, evaluated clinically, and finally was also validated against the HFO area identified from intracranial EEG data. Here we present the HFO's localization results for a 15-year-old girl with encephalomalacia in the right middle cerebral artery area who underwent epilepsy surgery and became seizure-free. We initially localized all the detected HFOs with a WMM algorithm that we described before and overlaid the HFO map on the resection. So both techniques, they localize the HFOs in the vicinity of the lesion, though MEG and high-density G, they present like slightly different localization results indicating different sensitivity profiles. The HFO zone was also overlaid on the irritative zone that was defined by the dipoles, but we see clearly here that it was much more focal and specific than the irritative zone that was assessed by the dipole fittings. To examine the ability of high-density G and MEG to localize interictal ripples, distinguish between ripples which occur at the same time with spikes and independent from the spikes, and evaluate their localization value as biomarkers of epileptogenicity in children with drug-resistant epilepsy. We extended the previous study to a cohort of 20 children with drug-resistant epilepsy who underwent epilepsy surgery, and they had simultaneously high-density G and MEG recordings as part of their presurgical evaluation procedure. So we classified ripples into 3 groups, considering their temporal relationship with interictal spikes. We had ripples identified non-invasively with MEG and high-density EEG, which were overlaid on interictal spikes. We had ripples which occurred alone without the occurrence of an interictal spike at the same timing. And finally, we have interictal spikes alone without the occurrence of a spike on top of them. We localized the ripples by using the WMM algorithm, as we described before, and we assessed the concordance of the non-invasively localized HFO area with the HFO zone defined by the intracranial EEG recordings and the resection, which both of them, they serve as gold standards. Ripples were detected in 16 out of 20 patients with both scalp EEG and MEG. High-density EEG detected more HFOs than MEG, with a rate of approximately 1.2 events per minute for the EEG and 0.23 events per minute for the MEG. And also we found that HFOs overlaid on spikes were more frequent than HFOs without spikes for both MEG and high-density EEG. For patients with good surgical outcome, which are proof of resection of the epileptogenic zone, the majority of ripples overlapping with spike was localized inside the area that was covered by the intracranial EEG for both electric and magnetic source imaging. This was in contrast to most ripples without spikes, which were localized outside the area covered by the intracranial EEG. And these findings indicate that HFOs without spikes are less likely to be epileptogenic compared to the HFOs with spikes. We also observed that the number of HFOs with spikes was significantly higher inside the resection for good surgical outcome patients compared to poor outcome patients for both EEG and the MEG. And this indicates that the resection of HFOs with spikes localized by the EEG or the MEG is associated with the patient's outcome. In contrast, the number of HFOs without spikes were not different between good and poor outcome patients, indicating that the resection of HFOs without spikes is not associated with the patient's outcome. A critical part of the presurgical evaluations of patients with epilepsy is also the precise localization of the eloquent cortex. These are the brain areas which are responsible for the different physiological functions of the human body. And we see here like how my team deals with the localization of different areas in the brain, which corresponds to the eloquent areas. My team develops experimental designs which are particularly suitable for children in order to allow mapping the different parts of the eloquent cortex. In this kind of experiment, we map different parts of the eloquent cortex by stimulating with compressed air puffs different fingers of children, and we're able to localize the activity that corresponds to the somatotopy of the primary somatosensory cortex. Source localization with the MEG allows also to map the entire brain network that is involved in the somatosensory processing. Let me display the video. So here we see some of the somatosensory evoked fields from pneumatic stimulation, and then by using source localization, we're able to map the entire network. We see activity first in the primary somatosensory cortex, in the few milliseconds later in the primary motor cortex, and finally activity in the secondary somatosensory areas. So by using this kind of source localization techniques, millisecond by millisecond, we're able to localize and map the entire network in the brain. Mapping the motor cortex in children is always more challenging because we have to ask the child to constantly move his finger for several times, and this is a quite boring task. And these experiments are almost impossible or very difficult particularly for young children. And my team is working now in experimental designs that they involve more child-friendly setups in order to allow the children to be in a child-friendly environment and be engaged in this kind of activity. So we see here, for example, like an experimental setup where we involve the different kind of child-friendly visual stimuli, and we ask the children to move their fingers corresponding to different kind of classified stimuli. And by using this kind of experiment designs, we're able to localize the primary motor cortex with quite high precision in children, typically developing children and children with epilepsy. So we can conclude based on all these findings that our research suggests that non-invasive electrophysiological techniques such as the MEG and the high-density EEG, they can facilitate the presurgical evaluation of children with drug-resistant epilepsy and potentially improve their surgical outcome. So for all these efforts, which are supported by NINDS, the Cook Children's Health Foundation, and the Dodson Endowment, I would like to thank all the patients and families who participate in our studies, and also the members of my group for their dedication to my research center's goal. Thank you.
Hi, so we're now in the Q&A portion of our masterclass. So if anybody would like to ask questions, please put them in the chat. So our first question is, you did not mention anything about OPMs. Do you see any application of OPMs in epilepsy?
Okay, that's a great question. The OPMs has been developed recently in the field as kind of a replacement of the MEG, and are at the beginning of their development. So far, I think it will take significantly some time this kind of technology to be translated clinically, because the current technology does not offer significant advantages compared to the conventional MEG, because in epilepsy, in the presurgical evaluation of patients with epilepsy, usually the child either stays still or should sit, sleep, or laying down on a bed. And then I see that the OPMs right now, as they are currently designed, they seems quite uncomfortable for these kids. And most importantly, the recordings they are performed in the magnetically shielded room. What I see in the future as significant development of the OPMs is when they will become strong enough and sensitive to record magnetic activity from the brain outside of the magnetically shielded room. Then this will be a pioneer breakthrough development in the field.
So our next question is, do you believe that other source localization methods can offer better localization findings compared to the equivalent current dipoles?
Oh, okay. So then, yes, there's some studies that they have shown some benefits from the distributed source models, for example. And as I mentioned in my talk, in specific applications, for example, when we have to localize oscillator activity, for example, like the high frequency oscillations, in this kind of case, yes, we need kind of different source localization methods, like more advanced. But most of the recent studies, they don't see any kind of significant significant improvement of the source localization of the other methods, like compared to the interictal spikes that is clinically well established. Of course, like there's several groups working on this field, and there's more things to come. But right now, I think that dipole fitting, it's a well-established method, and by considering a specific group of dipoles, as we present in in one of our recent papers with the clustering, they can provide sufficient results for localizing the irritative zone and even the seizure onset zone in some of the patients.
Thank you for that answer. So then, how do you see the future of MEG and HD-EEG for the next years as tools in the pre-surgical evaluation of patients with epilepsy?
So the MEG and the high density EEG are two techniques that they are under. There's no significant use of them in the clinical practice in several research centers. So you see MEG used in few epilepsy centers, like usually the level 4 centers. And I see that like this is a kind of a booming technology that, although it has been around for several years, we will see more MEG installations in either adult or pediatric hospitals, mostly for the presurgical evaluation of patients with epilepsy. And now I think that there's more people realizing with the most recent findings that is not only the MEG, but also the high density EEG that has to offer significant information, both about the localization of the irritative zone or the epileptogenic areas, or even the eloquent cortex. And these kind of two techniques, they should be used together. And ideally, they should be combined in one solution, as I showed in my data. MEG was one of the first companies who offered this kind of simultaneously MEG and high density EEG recordings. But actually, we see now the fruits of all this kind of initial thoughts, initial developments. And I'm pretty sure that like these technologies that now they're mature enough to be translated to the clinical practice.
Thank you. So another question that's come in has actually said, first, I'd like to thank you for your great lecture, and I would also like to understand the reason for choosing peak of spikes for EEG-based source localization rather than other time points like half raised time.
Mm-hmm. There's a recent study that's showing evidence that if you localize the activity not at the peak but at the onset of the spike, you can localize the epileptogenic zone with higher precision. When we use this kind of method in our own data, we didn't see that to be confirmed. However, like there's still a lot of work to be done on that, especially this kind of information. We can, if we have a lot of spikes, ideally we should be able like to map all the transition from the onset up to the peak of the spike, and there's a lot of work to be done. And then I think that all these kind of new ideas about to localize the spike either at the peak or the beginning should be confirmed by several different groups in clinical practice.
Okay, so the follow-up question to that has been asked is, also I would like to know your opinion to combine DTI in order to distinguish propagation due to structural connectivity.
That's an excellent question. So that's a different topic I'm working. I also work on cerebral palsy and mapping the structural abnormalities in children with cerebral palsy, and the multimodal integration of different modalities there has been proved that it has to offer a lot. The combination of different neuroimaging techniques that depict both diffusion imaging, for example, or structural abnormalities and functional abnormalities, like this is the ideal way to go. And what this question implies is, and this is a great suggestion, like future studies, they should also consider the DTI as a kind of a tool for mapping the structural pathways where the activity should travel. And with high-density gen MEG, we should ideally map the transition of this activity from the onset to other areas of the brain.
Thank you. So that was our final question that's being asked today. Thank you, Dr. Papadelis, for your time in presenting this masterclass. It's been really insightful. And thank you, everyone, for attending this masterclass today. And we hope to see you at future MEG masterclasses. Thank you.
Thank you.